So we are recording. We're here. Of course, nobody can see anything as I'm like, are we here? And you guys can't see what I'm looking at on my screen. So very fun. Okay, so today we're going to further talk about what else is going on. Okay, we're going to talk about angina. We're going to talk about some other forms of cardiovascular disease and how those things are going to manifest themselves. And then also, more importantly, we're going to talk a lot about how we can use exercise and how we can use physical activity as a way to reduce all of these things. Okay, so I know that I introduced this. We're going to talk in more depth now about something called angina pectoris. So angina is pain, okay? It is pain that you experience not in your heart, okay? It's a very existential thing, right? Like you're hurting my heart in some ways. But it is pain that accompanies the lack of blood flow and the lack of oxygen to certain areas of cardiac muscle that is felt in the surrounding tissues, okay? I believe that I mentioned last week on one of the days that the heart does not have the typical afferent pain, what we call nociceptors. They're receptors that sense things that result in pain, okay? The heart does not have that kind of innervation. It's not like your hand or your foot or even other internal organs. So when the heart is experiencing ischemia and it lacks oxygen, it has to run anaerobic metabolism, and that accumulates lactic acid. The hydrogen ions from that acid are going to activate nociceptors that are specific for acidity, okay, in surrounding tissues, and you're going to get this pain very, very often. It's called pectoris because you get it sort of in your upper left shoulder, into your left bicep, okay? You may feel it in the upper part of your chest. It may radiate up into your neck, okay? And so this is lack of blood flow here, lactic acid accumulation in the cardiac tissue, and then we're going to get this, okay? It may radiate. And so when we talk about things radiating, the pain is going to kind of start in one place and it's going to move outward from that particular place. And so it may start sort of right here, kind of around, right, your kind of clavicle on the upper left side, but it may radiate. You may feel it down into other places. It may go into your back. It may radiate up into your neck. The neck one, it seems to be especially more prominent in women, but that's what's happening, okay? This is one of the primary symptoms, okay? A primary symptom of cardiac ischemia that is likely caused by coronary artery disease, okay? So in some circumstances, if you experience angina, we will say you're having a heart attack. What you're really having is something called a myocardial infarction. A myocardial or an infarction, or what some people call just an MI or an infarct, is there's localized ischemia, and that then is going to lead to some dysfunction of that cardiac muscle. And so this pain is one of, okay, along with dizziness, right, or even people feel sick to their stomach or something, but just pain is one of the hallmark symptoms of a myocardial infarction. Very often, angina tends to come on or begin when people are doing things that require the heart to work harder than they do at rest, okay? It can very much happen at rest, but if you're experiencing angina and you're just sitting there, then you very likely have a blood clot or something that has really kind of broken off and is having some kind of acute change in your blood flow, okay? But during exercise, Going upstairs. You see it a lot in places where there's a bunch of snow, when people go out and they start shoveling snow, okay? Upstairs, playing sports, okay? Lifting weights where people are going to hold their breath and Valsalva. Weirdly enough, there may also be things if people are straining, trying to have a bowel movement or something, but things that make blood pressure go way up and make the heart work a lot harder are then going to necessitate more blood to the heart. And if there is a blockage or an almost complete blockage in some areas, when the heart needs more blood flow, that's when that not getting enough through is going to become a real problem. Okay? So if a person experiences angina, they need to go to the hospital immediately. Okay? Immediately. You, of course, want to get them down and get them calmed down and those things. That's one of the hallmark signs that you've got this kind of very, very progressed atherosclerosis and that there's going to be blockages and things that are happening. Okay? So, for coronary artery disease, and I think we also just briefly mentioned this, okay? So, if you're experiencing angina, that likely means you have coronary artery disease. We can use exercise as a way to treat it long term, okay? It will remodel those coronary arteries, it will strengthen the cardiac tissue, and improve blood flow to those areas, which is good. But we can also use exercise as a diagnostic tool, especially if you've experienced angina. You experience it, right? You call an ambulance, you go to the hospital, and they're going to put you on an EKG, which here's a normal EKG, and they're going to watch your cardiac rhythm. People that are experiencing ischemia and therefore are likely going to have angina are going to very, very often have abnormal cardiac rhythm. There's going to be some problems in the cardiac conduction system. One of the hallmark ones looks like this. It's a thing called S to T segment depression. So remember, we have QRS, and then here's the T, okay? Normally, S comes back up to baseline and then is flat, and then you get the T. People that are having problems with blood flow to the heart and are experiencing ischemia very often get this depressed, where S, after S, it does not come back up. It's going to stay down until we get sort of repolarization in the ventricles. And so it looks like this, okay? This is called S to T segment depression. It is one of, if not the best indicator, okay? The best diagnostic indicators of coronary artery disease that has associated cardiac ischemia, okay? If this happens at rest, big problems. If it happens during exercise, it's a problem. It's not the world's biggest problem. But this is what we do. You have a heart attack, you go to the hospital, they put an EKG on you, and they try to recreate the heart attack. Get on this treadmill and start walking right now, okay? They've done this to my mother like 4 times. My mom, weirdly enough, has several autoimmune disorders, and she has some narrowing in her neck, and so where the nerves are going to leave the spinal cord through the foraminal spaces. She does stuff where she reaches up over her head, or if she does silly things like try to start their 50-year-old lawnmower that my parents refused to get rid of, where they pull a lot like this, okay, and you put strain on her neck. She does that, and she irritates those nerves, and then she gets pain because of the narrowing in those things that presents in like the exact same place as angina. And it's happened like 3 or 4 times. And every time that it happens, they call 911 because you can't be too careful about these things. If it is actually, because she has a history of cardiovascular disease in her family, they call 911, she goes to the hospital. She also feels dizzy and lightheaded when it happens as well, which is another kind of thing. And they go, and they put the EKG on her, and they put her on a treadmill, and she's fine. She goes all the way to VO2 max, basically, and she's fine. And she's now like on a first-name basis with them, and she was like, I don't want morphine this time. Normally when this happens, you go to the hospital, they do a couple of things. 1, they're going to check all of this, but 2, they give you morphine, to calm you down, okay, and to make you feel good. They give you something called nitroglycerin, which is a very, very potent vasodilator. It is meant to, it's the cardiac equivalent of like an inhaler for people that have asthma, okay? It's going to dilate all of the blood vessels in your coronary arteries, basically it lowers blood pressure and makes it easier for blood to flow, okay? You do all of these things collectively, and it's meant to kind of calm you, lower your blood pressure, and make all of this go away, theoretically. Then they can do their diagnostic things and they can check out some stuff, okay? So you go, they exercise you. In some instances, if you can't exercise, they give you a medicine. They give you a pill. And the pill causes progressive increases in, it's basically epinephrine, like a dosed out of epinephrine. And it makes your heart perform just like you're doing a maximal exercise test. You're sitting there and your heart starts at like rest. And even though you're sitting there, it ramps all the way up and your heart rate and your stroke volume increases and your cardiac output goes up just like you would rinse or something, okay? I've seen a video of it happening. When we lived in Mississippi, okay, the cardiologist in Oxford, this little small town where the University of Mississippi is, one hospital, one cardiologist, that was his preferred way of doing this. Give them the drug, don't even bother putting them on a treadmill, because we'd send all of our students there to do like internships and stuff. Don't get on the treadmill, just EKG here, sit there, I give you a pill, watch. And our students would come back and talk about like how freaky it was. The people would really like get freaked out. They're like, I'm sitting here and I'm doing nothing. And yet, just boom, 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 just like you're running sprints or something. Okay? So that's what's going on here. You have the pain. There are going to be these underlying potential arrhythmias that we can diagnose. All of this then tells us, we think you have atherosclerosis, we think there's blockages, and we need to do something about all of that. Okay? Okay. So, talked about those two kinds of things. So, what are we going to do if you've got a person that has coronary artery disease, they've had some angina, okay? And so we've got to break angina into what we call stable and unstable angina. So stable angina is I do something, I raise the work of the heart, it comes on, I stop, the work of the heart goes back down, and the angina goes away. Okay? That is stable. So what happens if you exercise a person that has stable angina? Generally, exercise training is a benefit to these people. Okay? We can usually do it safely in them. We start them off at a very kind of low level, but they can usually benefit from all of this. If you have stable angina, the risk from exercising you are relatively minimal. You want to do it, you're considered a high-risk person by the risk stratification. We're going to monitor you with an EKG and those things. But generally, the risk of them having a myocardial infarct or something even worse, some kind of sudden cardiac arrest with stable angina is relatively minimal, okay? If you have unstable angina, we cannot and we do not exercise those people until your clinical symptoms, so until your angina symptoms become more stable. You're sitting there, you have angina. It comes on, it goes away. Comes on, it goes away. You exercise, you get nothing one time, and then the next time you get some. Right? Or you exercise and it comes on, and you stop exercising and it stays. Okay? These things, right, are poor clinical symptoms and are indicative. Unstable angina is indicative of much more progressive blockages in more than one kind of a place. It may also mean that there has been more extensive ischemic damage to the. Okay? So this is a much worse kind of condition that may need to be more immediately addressed with bypass surgery or something else. Okay? Our primary goal in people that have had angina, that have coronary artery through exercise, is to raise what we call the ischemic threshold. Okay? We want to improve their cardiac function to a point where the amount of work, the speed at which they're running, right, the grade at which they're going up, or the work rate on the bike, whatever they're doing, that they can do more work before the heart becomes ischemic and before the angina comes on. Okay? That's going to help us, one, improve their overall prognosis, but it's also going to help us by allowing them to do kind of more normal things in their daily lives without this pain coming on and therefore having to stop. Okay? That's kind of our big primary goal. Okay. So if we look at the sort of American College of and the American Heart Association recommendations for exercise programming, we need to, before you start exercising, if you've got coronary artery disease, we need to be able to define for a person what angina is. They need to be able to identify what the symptoms of angina are, right? Identify those within their self, like, oh, you're doing this, this is angina pain. Your pain is, this is what it's causing it. That goes away, people know what it is. Okay? So, and then they need to be able to describe the immediate treatment for it. Some people have acute rescue medications they can take. And so what we tend to do in these people then is to say, we're going to start off at a very low exercise intensity at relatively short durations and a few number of days a week so that you can kind of exercise, usually starting off with walking for brief periods of time on flat ground. And the goal is to do this without experiencing any symptoms of angina. And we slowly begin to increase. And that lets us ramp things up and get some positive adaptations. Okay? I've already mentioned what a myocardial infarction is. This is the thing that is often happening that's associated with the angina pain. But an infarct is going to, the infarct portion denotes that there is damage. There's death of ventricular, especially ventricular muscle fibers. Okay? And so this is due to prolonged ischemia. Not simply, I'm starting to work out and then I begin to get angina pain, then I stop after like 10 seconds and it goes away. That's pretty short term, not a huge issue with death of tissue from that, but much more prolonged ischemia causes this infarct. Okay? So the degree to which we experience ventricular dysfunction depends very heavily on how much of the heart is permanently damaged. The greater the damage, okay, then the greater the degree of ventricular dysfunction and the more long-term problems we're going to have. Okay? Typically, a person that has had a myocardial infarction, we prescribe a medication called a beta blocker. Okay? Called a beta blocker. It lowers heart rate, it lowers blood pressure. What it does is it blunts or attenuates the effects of epinephrine and norepinephrine on the heart. Okay? So sometimes if people have, you don't have to put your hands up or anything, but my guess is some of you, if we did a regular class, sort of regular semester, and you had to get up and present at the end of class with your group, some of you would be very anxious about that, right? Very anxious. For certain kind of manifestations of that, they will prescribe people beta blockers. And what it does is it limits, right, that stress response that you're getting in normal healthy people, and so you feel calmer. One of my PhD students has this problem, has beta blockers that they take whenever they have to present. And it seems to really help. Same kind of thing, lowers blood pressure, lowers the work of the heart, which hopefully then is going to prevent kind of further damage that's going to be. Okay? So if you have had a myocardial infarction, you have damage and you have death of ventricular tissue especially, if we exercise you, okay, we're going to notice a couple of things. Your cardiorespiratory and hemodynamic, or so blood flow responses, are going to look different than a regular person. If you just have angina, your responses look pretty normal. If you've had an infarct, then we're going to see marked reductions in heart rate, especially in stroke volume and cardiac output. We're going to see changes in the blood pressure response, and the flow response, okay, is going to look off because your ventricles don't function as well as they normally should, okay? These people have a reduction in aerobic capacity of maybe 30 to 50%. You exercise them and their VO2 max has gone from 40 down to 20, okay? Imagine any of you guys, many of you turned in what your VO2 max responses were from last week. Imagine you just had a myocardial infarction, cut your number in half, okay? Cut your number in half. You're at 40, now you're at 20. You're at 35, now you're at 17 and a half, okay? And so what happens because of all of this is people that are post this have a hard time doing anything more than walking, okay? They have this, their VO2 max is down because their cardiac output is down. And that is very often due to, because of improper ventricular or suboptimal ventricular function, they have decreased stroke volume, and they sometimes have decreased heart rate as well, okay? So these people are also, when you have tissue death in the ventricles, you have a much, much higher risk of there being ventricular arrhythmias or dysrhythmias, so that there's an impairment in cardiac conduction in the bundle of His and the Purkinje fibers that are running through the ventricles. And this is going to lead to instances where the ventricles are not contracting in proper timing with the atria, okay? They're not contracting in proper time to be able to either receive blood from the lungs or to eject blood off to the lungs or out into normal cardiac tissue. And that means people that are post-MI are at significantly increased chances of having a sudden cardiac arrest at rest and during exercise, especially during exercise, right? So in some patients, we can get them out after their infarct, they've survived, okay? They may experience residual ischemia and scarring. Not everybody, okay? They may have decreased left ventricular contractile force, which can put them at an increased risk of something called congestive heart failure. Okay? If your left ventricle cannot contract forcefully enough, one of the consequences is that it cannot raise the pressure of the left ventricle over aortic pressure, and you can't eject blood out of the heart. And you basically drown, your heart drowns, okay, in a way, because it cannot eject any blood out. And it backs up into your lungs. It's a really, really nasty kind of thing. This is what's called congestive heart failure. Okay? So that then leads to, right, this contraction force goes down, so your ejection fraction and stroke volume are going to fall. Right? You have this sort of blunted blood pressure response, so it's going to be hard to do things. But in some people, okay, post-infarct, you may have even worse things, which are going to be, right, we can treat some of the other ones, but you may have damage and improper function of the SA node or the AV node, something we call chronotropic impairment. You cannot transmit increasing signals from the SA node to the AV node out to the rest of the heart. Okay? So this restricts your ability to increase heart rate, it restricts your ability to increase cardiac output. Okay? This means these people cannot exercise at very, very high levels. Okay? Despite all of this, the primary treatment for people that have had an MI is exercise. We want to stabilize their symptoms, right? And then try to get them to exercise to lead to these positive adaptations, okay? If you can train people post-MI, which we do a lot now, lots of really good jobs if that's what you want to do. You make more money than if you're a physical therapist, okay? Working in a cardiac rehab facility. You can increase their aerobic capacity, so you can make their VO2 max go up. We can, with exercise, make their cardiac tissue look more like normal. You have some that has died, we'll make some more, okay? We'll make more, okay? We can decrease, right, their submaximal heart rate and blood pressure at any given work rate. So this can lead to some relief of their angina symptoms, okay? As we can repair some of that cardiac muscle, we can reduce some of those things, okay? And then we also know, like with everything else, when I exercise. So their MI is likely the result of coronary artery disease caused by atherosclerosis that has progressed far enough that this happened. Chronic exercise very often can lower percent body fat, it lowers blood pressure, and it lowers our cholesterol or our blood lipid levels, which is going to have positive impacts on further progression of atherosclerosis and coronary artery disease. Okay? And then these things cannot be sort of discounted. You're post all of this, you see lots of people that are depressed, they can't do normal things. Exercising them makes them feel better about themselves. They feel like they can do more things, that's self-efficacy. And there's generally these very positive kind of mental health outcomes as well. Okay? So let's walk through this a little bit. Okay? There are various stages of what we call cardiac rehabilitation. So stage one, okay? You've had a heart attack. Phase one is going to happen in the hospital while you are on bed rest, okay? One of the first things that you do is called an orthostatic challenge, okay? If you take testing in prescription class, you guys may do a lab where you do an orthostatic challenge. Orthostatic challenge means we are doing something. We're going to acutely change your posture and challenge the ability of your baroreceptors and things to change and compensate from a blood pressure response. Okay? Anybody ever done something, stand up too fast, if you've been down, stand up too fast, you feel lightheaded? That's an orthostatic challenge. That is from improper. It often happens like you've been running or you've been biking, you have lots of blood pooled in your legs, and you immediately like lay down and you try to hop right back up, and all the blood is down here, and you cannot respond and control blood pressure correctly to maintain pressure to the brain. That's what this orthostatic challenge is going to be. All they're going to do initially is let's challenge the heart to try to regulate blood pressure. Sit you up, okay? Back down. Sit you up, back down. Sitting up is okay. Stand, okay? Stand quickly. Stand and walk just a little bit. That's the very, very first phase, okay? So this is when you're on bed rest. So phase 2 through phase 4 are going to range from a little bit of sort of what we might think of in phase 2 as inpatient supervised things, and then 3 and 4 are generally outpatient. Sometimes 2 now is outpatient as well. You've been released from the hospital, but what you're going to do is you're just going to come in and we're going to supervise you, and you're going to walk. And then if walking is okay, maybe we have you jog a little bit. See, here we can see our gentleman. He is in this cardiac rehab facility. He's got his EKG on, right? And we have his cardiac rehab specialist is here. She's checking his blood pressure while he's exercising. They're monitoring his EKG while he's exercising. They're asking him if he's experiencing angina or anything. But he comes in, especially in phase 2 and phase 3, it's supervised. So we do these large muscle group aerobic kind of exercise that may be walking or biking initially at very, very low kind of levels. And it's rhythmic. It's not weightlifting. It's not something that's going to jack our blood pressure way, way up. But you come in, we monitor you, we start you off, you come in 3 days a week. We do these things. This, okay, this is now the standard of care for people after a heart attack. Standard of care means insurance pays for this, okay? And so because insurance pays for it, every hospital now has a cardiac rehabilitation unit, every one of them. There are outpatient, independent places that are cardiac rehabilitation units, okay? And so from all of that, 1, it creates jobs that are well paying. 2, because there's lots of evidence that this works, people that go through this have a significantly reduced rate of a second infarct. They have much, much better prognosis for later in life. And so this is now standard of care for everybody, which is great, okay, which is great. When I was a grad student at the University of Georgia, we had a master's program. It was a clinical cardiac rehabilitation master's program. And so because of that, we had a lab where people came in, and at a very reduced cost, they did their cardiac rehabilitation in our building, which was cool because there was lots of opportunities for people to see what was going on. In the program, you got taught how to read EKGs, you got taught how to program all of this stuff based upon these things. You got to interact with some generally lovely older folks. You know, if you like all of those things, lots of them just want you to talk to them. They're just happy to see somebody. Their life is like living in the pandemic. I just want to see somebody else. I want to talk to somebody else. They really enjoyed these kinds of things. The downside was about once a month, somebody would have to call 911, and the ambulance would have to come. I don't think we ever had anybody that was like seriously, but they'll like their EKG would look weird, or somebody would pass out, and they'd have to call the ambulance. But there are programs for this. There are master's programs. Texas A&M has one now. There are several other ones that are around. If you guys are interested in these kinds of things, there are some really, really good jobs doing a lot of this kind of stuff. Okay. If you're from a place that's a big city, there's internship opportunities. If you want to look around, if you're interested in this, one of my former master students does. He is an exercise specialist. He runs a lot of the stress tests and things at a hospital in Tulsa that these people do. But they also have these people that can do the rehab side of things. Okay. Okay. Questions about any of that? Are we okay? Do you all need to get up and see if we can cause anyone to have angina right now? Get you guys up, get you woken up a little bit. Maddie's looking at me like, oh dear God, no, not that. Please don't make me do those kinds of things. Okay. So we're going to move away then from coronary arteries. Zach, you had a question?
Yeah, you mentioned like the medication for
Yes. Yeah, side effect of taking the vasodilator is you're going to get lightheaded. Like a regular person that takes that, and you can sometimes have more difficulty maintaining blood pressure, and so you may pass out, like lose consciousness a little bit. In those ways, while those things are going on, it's going to be more difficult. If you have problems regulating blood pressure, which means postural challenges, exercise challenges, and those kinds of things, if you've had nitroglycerin or something, it may be a bit of a problem. Okay. Interestingly, you guys can go to Walmart or Whole Foods or wherever you want to go, GNC, and you can buy something called L-arginine. You guys ever heard of something called L-arginine? Okay. L-arginine, arginine's an amino acid, right? Am I crazy? I think it's an amino acid. It's been a long time since I've had biochemistry, everybody. A long time. Okay. Going on like 21 years since I had biochem. But L-arginine is a precursor to nitric oxide. Nitric oxide is a thing that is released by the endothelial layer of your blood vessels, which we talked about last week. It's released by this endothelium. Nitric oxide relaxes the smooth muscle around those arteries and arterioles and lowers blood pressure and allows more things to come through. You can buy L-arginine, which potentially allows you to make more or better nitric oxide, okay, which then may function in some ways to have better vascular health on these things. There's not a lot of evidence that long-term it's super great if you have lots of problems, but it's a thing. Okay? Okay. So we're going to move away from the heart now. Okay? What I want you guys to note with this is we're going to talk about blood flow to the brain now, but the underlying cause and problems are very, very similar to what is happening in the heart. Okay? But when it affects the brain, we call it something different. So an interruption in blood flow to a certain area of the brain is called a stroke. Okay? This is like having a myocardial infarction, but it's in your brain. Okay? Strokes generally get grouped into one of two categories based upon the thing that is leading to or causing the disruption in blood flow. We can have what's called an ischemic stroke. These are the most common ones. An ischemic stroke is due to a blood clot. Okay? You have atherosclerosis, so you've got narrowing in these arteries that are in your brain, and you get a clot from someplace else, or you get a piece of a plaque from up here that breaks off, and it gets stuck, And so blood clot, and we're going to have no blood flow past this point to whatever area of the brain is downstream of that. Right? This one's the most common. That's called an ischemic stroke. A hemorrhagic stroke, on the other hand, is going to be due not to a blood clot, but to a rupture in a blood vessel somewhere in the brain, where the blood is going to leak out of the vessel and pool in an area of the brain. And as it fills up with blood, the pressure in that area, because your brain is, the pressure increases, and that pressure can get to be so high that it squeezes off those arteries. If the pressure in that area of the brain exceeds systolic blood pressure, then blood flow can't get through those areas. And so when this happens, then you're not going to get blood flow past the area of the increased pressure. Right? The ruptures often take place at locations that are called aneurysms. Okay? Aneurysms. So from a purely medical terminology standpoint, an aneurysm is a place in a blood vessel that is weakened. Okay? It's weakened. And as it becomes weakened, then it loses some of its elasticity, and it can have these little pockets on it that will balloon out. And it becomes very, very weak and very thin, and it's like a balloon that's been overstretched and overfilled, and it can burst. Okay? Oftentimes, in kind of regular medical terminology, or you hear it on television shows or in the popular press, they will refer to what happens when you get a hemorrhagic stroke. They will refer to the rupturing as the aneurysm, right? You say things, right, like Bria had an aneurysm, right? What they mean is, well, she had a hemorrhagic stroke where there was a rupture at an aneurysm in those places. They're very often used somewhat interchangeably. I don't really care. I'm not going to ask you something that's specific about all of that, but I do want you to appreciate, okay, that there are kind of some different uses of those terms. Okay? You guys watch Grey's Anatomy? Some of you have at some points, yeah. So these are like no Dr. Black, not Grey's Anatomy. Okay? Is that on Netflix now? I don't know. We used to watch Grey's Anatomy when it was first out, and then after like 3 years, you're like, okay, it's the same show over and over and over again. When you get to a certain minute, they put kind of the sad song on, and then, right, and then she voiceovers on the whole thing. But Derek, who's Patrick Dempsey's character on Grey's Anatomy, was a cerebrovascular surgeon, and he would try to repair aneurysms and repair these kinds of things. They open your skull up and do surgery. That's what he was always doing. I need better references. I need to watch some new medical shows so that I have something better to kind of talk about with you guys. Here's an aneurysm, weak spot. It's ballooned off, and then it will break, and then blood leaks out and surrounds this tissue. It fills up, it swells, pressure goes up, pinches off these arteries and the surrounding ones. Okay? In general, hemorrhagic strokes are worse and affect larger areas of the brain than ischemic strokes. Okay? Because the blood leaks out, it can affect a much larger area than simply having a blood clot in one particular place. Okay? That's kind of what's going to happen in the midst of all of this. So, strokes are the fourth leading cause of death. They become really, really, really much more prevalent, okay, as we age, especially when we get over the age of 60. Okay? It is one of the leading causes of adult disability. Strokes and osteoarthritis are kind of the leading causes of adult disability. And that disability comes from there's been a lack of blood flow in a particular area. That brain tissue that underlies things dies. Unlike cardiac muscle, unlike skeletal muscle, unlike peripheral nerves that go to things, when neurons die, when neurons in the central nervous system die, they don't come back. Okay? We cannot regenerate those things. And so once they're gone, they're gone. Okay? And so when a person has a stroke, what is happening is we're running against a clock to try to restore blood flow to a particular area so that we can restore or hopefully limit any kind of cell death to the neurons in that area of the brain. Okay? So this is kind of a mind-blowing thing, is that every 4 minutes somebody in the US dies from a stroke. Okay? So there's about 130,000 people that die from strokes every year. We've got about almost 800,000, probably a little more than that, have a stroke. Most of them are new strokes. However, if you've had one, your chances of having a second go way, way up. About half of Americans have a risk factor for a stroke. Okay? Especially older adults, if you're hypertensive, you're at risk for a stroke. If you're sedentary, you're at risk for a stroke. Okay? So about 90% of strokes are ischemic. They're due to blood clots, okay, and those kinds of things. So big deal. If you drive on Interstate 35 or on Interstate 40, as you get around Oklahoma City, you will see these giant billboards, and they will talk about we're a particularly bad place for strokes. Okay, so we have these billboards, and they will talk about know the warning signs. Okay, know the idea of this acronym called FAST for strokes. Watch for face drooping. Okay, watch for arm weakness. Watch for difficulty speaking, and then time. Call 911. We want to get help as quickly or as fast as possible. Okay. Strokes tend to present as numbness, weakness, slurred speech, droopiness on one side of the body. Okay, on one side of the body. You have a stroke on the left side of your brain, it will affect things on the right side of your body. The area of the brain where the blood flow is compromised will determine, is it a speech issue that's going to be a problem? Is it a motor issue, right? Ability to move that's going to be a problem, okay? Is it a cognitive issue that's going to be a problem? Because where you lose the flow, wherever that is in the brain, that area is affected, but maybe not some of the others. Okay? So most stroke patients are over 65. It's very, very rare that we see strokes in folks that are y'all's age, but it occasionally occurs. So the size and location of the injured area. Here you can see this person here. It had a very large hemorrhagic stroke. This area where it looks very, very dark here, lots of fluid over on this side of the brain. So you may have decreased motor function, so an inability to move correctly. You may have decreased sensation, especially in your extremities, depending upon where it is. There may be trouble walking because of the decrease in motor function or because of decrease in sensation. The proprioception gets messed up, so you can't walk correctly. You're weak. There may be vision issues. There may be speech impediments. So all of these kinds of things, if we can get you to survive the stroke, we can work on these things, right? We can try to teach some sort of new connections from the remaining neurons that are in your brain. And so people can usually get better at talking, they can get better at walking to some extent. Some people recover almost fully, okay? Other people, not so much. Zach, did you have a question? Oh no, they'll go in and they'll drain it. Yeah, they'll go in, they'll open your skull up and they'll close off the blood vessel. They want to get the pressure released and those kinds of things. Mm-hmm. Yes, absolutely correct. Okay. So if we take people that have had a stroke, it is very beneficial to try to exercise them. Okay. Exercise has very good and very positive effects on neuron function, okay, both in the brain and peripherally. So in people that have had a stroke, if we train them, we can see maybe a 60% improvement in their VO2 max. The act of moving and doing things is good for helping them to relearn how to walk and jog and run, okay? It leads to very dramatic improvements in their walking speed and their ability to carry loads and things. The primary or one of the major primary risk factors of a stroke is high blood pressure. So undertaking exercise training lowers your blood pressure, which then can lower your risk of having another stroke. So this is one of the big risk factors. Stroke is also going to be very highly associated with people that are type 2 diabetics who have poor blood glucose control. So exercise improves your blood glucose control. It improves blood lipids, which will hopefully maybe prevent some further atherosclerosis in those cerebral arteries. So it can kind of keep things from getting even worse in those particular areas. Same goes, obesity tends to be an issue as well. Okay. All right, let's take a little break, and then we'll talk about hypertension. Let's take a break until noon, okay? Until noon. But I found a paper that showed, it just came out like yesterday, where they induced some muscle damage in mice, and then they put like ice on them, and they found that basically it would be meant to mimic like if your muscles were sore. And they found that icing your muscles after they were sore significantly retards how quickly they are going to be able to heal and come back to normal. So basically, icing is dumb, is what our takeaway from this should be. If your muscles are sore, do not ice them. That is not a good plan. It's like a week later, there were still more like necrotic and damaged fibers in the condition that was icing every day versus the people that weren't, or the animals that weren't. So again, here we are disputing these very kind of well-held sort of facts on it. So, okay, when you learn more about part 2 of the big water, small water, let me know, and we can do something. Okay. So we're going to move from stroke. We're going to talk about hypertension. Okay. Hypertension is high blood pressure. So it is sometimes referred to as the silent killer because for a lot of people, you have hypertension, there are no real symptoms of having hypertension. You don't know what it is, it's just kind of there, okay? And you may have, you may have headaches, you may have vision problems, there may be difficulty breathing because high blood pressure is going to back blood flow up into the lungs. You may feel tired. Maybe you have angina pain, but maybe you don't, okay? There may be blood in your urine. There may be irregular heartbeats. These are some of the common symptoms if it's very, very untreated and very severe. But a lot of people don't have it. You have no symptoms. You don't even know that you're hypertensive until you're quite hypertensive, and there's already a chance of there being some kind of poor prognosis problems. Okay? So here's just looking at systolic pressure, diastolic pressures, and the kind of stages of hypertension that we're going to talk about, okay? So you're looking at systolic 90 over say 60, diastolic, you're in kind of this low blood pressure. Low is just lower than normal. Low is not always bad. Some of this is going to be a result of not having the proper kind of blood pressure cuff to take things. But then these ranges, right, 120 to 140 or 80 to 90 means you're pre-hypertensive, which means basically it's only a matter of time before you become hypertensive. 140 to 160 or 90 over 100 here is stage 1. 160 to 180 plus, this is stage 2. You'd be amazed at how many people are going to be in this untreated kind of up here stage 2 hypertensive stuff. There's a lot of really, really poor health outcomes, okay? Just to illustrate things in the percentage here, I'm showing you data from 2008, the NHANES survey data that we have updated. It's not that much different. We've done a reasonable job of at least preventing it from getting worse, but this is the percentage of age ranges that are going to report being hypertensive, okay? That are going to report being hypertensive. And so only about 4% of people in y'all's age range, about 20% of people in my age range, and you get this big jump once we get into our 50s and 60s, and so you look out here, people that are in their 70s or 80s, about 2/3 of people are hypertensive. So hypertensive is a progressive disorder, much like atherosclerosis, because that's very often what underlies it. It takes time to develop, okay? And so as it comes on with age, then hypertension is one of the underlying causes and underlying risk factors of all of our other kinds of cardiovascular disease. Okay? For a lot of people, we do not know why they are hypertensive. It's called essential hypertension. We have no idea what's going on there, okay? And so we know that it's related to age. We know that it's related to obesity. If your BMI is higher within a given age range, your chances of being hypertensive is going to go up. We know that it's related to your physical activity levels, okay? We know that it is related to the sort of underlying atherosclerosis process that is going on. And then in some people, it's related to both salt intake and to kidney function, okay? Did you guys talk about in phys, or maybe it would have been in anatomy, probably in human phys, did you guys talk about the role of the kidneys and the renal system in controlling blood volume and therefore controlling blood pressure? If you have impaired kidney function, then you're going to have a hard time controlling blood pressure. If you have elevated blood pressure, it can lead to damage in the nephrons, and it can lead to kidney damage, which is really, really bad. Okay, but some of the kidney function is related to salt intake. The kidneys are going to regulate urine output based upon salt intake and fluid intake and things. And so you're either going to retain more water at the kidneys, raise blood volume and raise blood pressure, or you're going to try to excrete more, which is going to lower blood volume, alter osmolality with the salt intake, and hopefully lower some blood pressure. There are some people that we call salt sensitive that can eat a small bag of Lay's potato chips and their blood pressure will go up like 20 millimeters of mercury, right? 20 millimeters of mercury. Boom, like almost immediately, because they're so sensitive to the salt. You eat salt, it draws the fluid into your interstitial space, or it draws the fluid, the salt gets into your plasma, it draws more fluid in, blood volume goes up, that raises blood pressure. Okay, so these things are going to be very, very key. One of the treatments for people that are hypertensive is to cut your overall salt intake. Okay, I know this because my father-in-law is hypertensive, and his doctor would yell at him to stop eating potato chips. Would he stop eating potato chips? Absolutely not. You would not do those kinds of things. So that's going to be a deal as well. We know in some ways that these things are related. Okay? But there we go. Okay. So Jerry Seinfeld, or a Seinfeld joke, what's the big deal with hypertension? And I need new references. Okay? So what tends to happen is if you are hypertensive, it can lead to hypertrophic cardiomyopathy in the heart, which is going to, as you narrow these arteries down, right, we're going to get the deposition of atherosclerosis or atherosclerotic plaques. Blood pressure goes up. As the pressure goes up, you're going to get a greater chance of damaging, so then you're going to get more atherosclerosis. It leads to hypertrophic cardiomyopathy. It's going to be a thickening of the outer walls of the heart, which is going to make them greater susceptibility to ventricular arrhythmias, okay, which then can lead us to greater chances of having a myocardial infarction. It can cause kidney damage. It puts us at a much greater risk of having a hemorrhagic stroke, okay. It puts us at a seriously increased risk of having blood clots because the pressure is so high that it will knock pieces off of these plaques at various points in the body, and then they can go and they can get stuck everywhere. Okay, so having the high blood pressure is going to cause or be the root cause of a lot of other risks that are going to go on with things. So we want to try to keep it down as best we can. Okay. Now, I want you all to appreciate that when you exercise, the normal response during exercise is blood pressure increases a lot. It needs to, especially systolic pressure goes up a bunch. This is good. This is okay, right? So if you take a person that is already hypertensive and you have them exercise, they're going to get an even more pronounced increase in systolic pressure, which really puts them at a great risk of having a stroke or knocking off a blood clot from somewhere, or knocking off a piece of a plaque, okay? If you have untreated hypertension, it may limit what we call your exercise tolerance. So because your blood pressure gets so high, but that may make you not be able to exercise as long or at as high of an intensity. You take antihypertensive drugs. You take beta blockers, you take ACE inhibitors, you take some pills. What they do is they limit the natural rise in blood pressure during exercise that we need to increase performance. And so antihypertensive drugs may further impair your exercise performance, meaning you cannot exercise at an adequate intensity to evoke positive adaptations. So the good thing though, if you're hypertensive, endurance exercise can result in about a 10 millimeter reduction in both systolic and diastolic blood pressure. Okay? If you can get about 30 minutes or so of exercise, and even if it's just walking every day, you can get this relatively modest reduction in blood pressure, which is very, very positive. Okay? Exercise tends to lead to decreased sympathetic nervous system output at rest, so it lowers epinephrine and norepinephrine, which helps to lower blood pressure. We can very often, in people that are just barely hypertensive, we can use aerobic exercise as a therapy or a treatment, so they don't have to take a drug, just go exercise, go for a walk. Okay? People that are fit but still hypertensive. The guy that I worked for my postdoc was hypertensive, but yet he ran like 4 marathons a year. He was very, very fit, but just had, because of family history, high blood pressure, has markedly reduced mortality rates, although, to be honest, a couple of years ago, he had a very bad heart attack because of his hypertension, even though he was super fit. So some people are just kind of going to be at a high risk no matter what we're doing, but this is good, okay? And then resistance training, on the other hand, is not that great at lowering blood pressure. Resistance training is good for older adults. It's good for people from a function standpoint. It's not as great for lowering, one of the things it's not as great for lowering blood pressure. That's why the activity recommendations include both aerobic and resistance exercise. Okay? So special considerations if you're exercising a person, right? If they're very, very hypertensive, we want to get them on drug therapy to get it down so they don't get an overly pronounced response during exercise. If during exercise their pressure gets too high, we need to stop. Okay? That could be some kind of problems here. Okay. Prescription for people with cardiovascular disease is basically the same as it is in a regular person. 40 to 85% of heart rate reserve. Okay, RPE ranges from kind of light to somewhat kind of moderate up into the kind of hard ranges. Very, very simple. It's pretty much the same thing. Okay, that we're going to do some kind of circuit training or kind of resistance training. We want to keep it at a reasonably low, kind of moderate level. Okay. These kind of things, take home message. Exercise good, CVD bad. That's pretty much it. Okay? All right. So, it is 12:13. What I'm going to do is